Welcome back to the deep dive. Our mission here is to synthesize specialized, high-level knowledge, the stuff that typically only comes after years immersed in a field, and deliver you the clearest, most actionable insights.
hmm
Today, we are strapping in for a deep dive into the absolute sharp end of critical care, the advanced logistics and rapid decision-making required in massive blood transfusion and hemorrhage management.
This is really specialized material. We're essentially taking excerpts from advanced educational slides, the curriculum designed for medical students, residents, and specialized trauma teams.
Right.
This isn't about blood types. This is about clinical execution. When a patient is actively bleeding, whether from trauma or surgery, the decisions regarding what to give, when to give it, and how much to give must be, well, precise and immediate.
And getting that right is everything.
Understanding these protocols is the difference between life and irreversible organ damage.
So, if you are a learner, or maybe you are prepping for a high-stakes meeting where these protocols are central, your mission today is to move beyond the foundational textbook facts. We are synthesizing the applied logistics, the subtle physiological compensations, the critical safety checks, and yet a cutting-edge philosophy of resuscitation.
Yeah.
We want you to walk away not just knowing the rules, but understanding the why behind them.
And our source material today is highly structured and authoritative, drawn directly from advanced concepts in blood transfusion and management. These are lessons honed in the trauma bay, structured to maximize knowledge retention and impact.
So where do we start?
Let's start the journey where all resuscitation begins, recognition.
Okay, so let's unpack this using the roadmap provided by the Advanced Trauma Life Support, or ATLS, classification. The goal here is recognizing shock before the patient is moments away from collapse.
Right.
Shock fundamentally is just inadequate tissue perfusion. The key realization this classification forces is that the body is an incredible compensatory machine.
That's the critical point. The body fights desperately to maintain blood flow to the two most vital organs, the heart and the brain.
Right.
If you wait for the easiest metric blood pressure to drop, you've missed a vast window of opportunity. The ATLS classification helps us track the subtle failures in that compensatory mechanism.
Okay, so let's break down the 4 classes of hemorrhagic shock. Let's track the body's response to volume loss, starting with class 1. This is the one that can lull you into a false sense of security.
It really can. Class I shock involves losing up to 15% of your total blood volume.
And what's that in real terms?
For an average 70-kilogram adult, that's up to 750 milliliters. The blood volume is down, but the body handles it easily. All the primary vital signs, heart rate, blood pressure, mental state, remain essentially normal.
So you wouldn't even know.
Not from the monitor. The systemic vascular resistance has increased just enough to keep the pressure stable. The key functional indicator here is that urine output remains robust, typically greater than 30 milliliters per hour. It's often an occult or, a hidden hemorrhage.
Okay, but if you're measuring a patient's output and they start dropping towards, say, 1,000 or 1,500 milliliters of loss, we're entering class 2.
Exactly.
And this is where the early warning systems start screaming, even if the blood pressure monitor is deceptively green.
Class 2 represents a loss of 15 to 30% of total volume. And this is where the sympathetic nervous system truly kicks in. The primary response is a rise in heart rate.
Tachycardia.
Tachycardia.
Yeah.
It's the body's simple physics solution. If the volume being ejected per beat is falling because of volume loss, you just have to pump faster to keep the total output steady.
And crucially, the BP is still normal here, right?
Exactly. The blood pressure is maintained by massive systemic vasoconstriction. The patient's skin might be cool and clammy. That's the body diverting blood from the periphery to the core.
But the number looks good.
The number on the pressure transducer still looks good. This is a critical trap for the unwary clinician.
What about the non-physical indicators? I mean, how is the patient feeling or acting?
They are noticeably anxious. This is partly due to the generalized stress response, the surge of adrenaline, and partly due to subtle hypoperfusion of the brain. You might notice they are restless or increasingly irritable.
Okay.
Simultaneously, the kidneys have locked down. They're conserving every drop of fluid, dropping urine output to 20 to 30 ml per hour. Tachycardia and anxiety are your frontline indicators of impending disaster.
And if those early warning signs are missed or the bleeding just continues, we cross the crucial line into class 3. We're talking about a 30 to 40% loss up to 2,000 milliliters.
Yes.
This is the definition of decompensated shock.
This is the crisis point. The patient has run out of reserve volume. The heart rate is now significantly elevated, trying desperately to maintain output, but the vasoconstriction alone can no longer hold the line.
And this is when the BP finally drops.
For the first time, blood pressure finally drops. And that drop in pressure means vital organ perfusion is actively failing.
That drop in perfusion has an immediate and, I'd imagine, catastrophic effect on the mental state.
Absolutely. Perfusion to the brain is compromised, and the patient moves from anxiety to overt confusion. They are difficult to communicate with, may be disoriented. Clinically, their urine output is nearly absent, just 5 to 15 ml per hour.
So at this stage, you're in full crisis mode.
At this stage, you are no longer contemplating intervention. You are initiating a massive transfusion protocol and mobilizing a surgical team immediately.
And finally, class 4. A loss of over 40% of total volume. This is profound, life-threatening collapse.
In class 4, the system is crashing. You see massive drops in BP, and the heart rate is racing at its maximum capacity. The patient's brain is severely underperfused, leading to lethargy or coma. Urine output is negligible. At this level of shock, you have a very short window to reverse the physiology before irreversible multi-organ failure sets in.
Okay, here is the critical pearl the source material hammers home. Hypotension is a late sign of shock. Why must this insight be internalized by the learner? Especially if they're used to treating patients with chronic hypertension where, a low BP is often the main concern?
Because you are fighting against the body's brilliant ability to lie to you. The sympathetic nervous system is so effective in classes 1 and 2 through adrenaline release and widespread constriction of the arteries that it can maintain systemic blood pressure against enormous volume depletion.
So it's compensating.
It's compensating brilliantly. You are essentially using a very tight container to hold less and less fluid. But the pressure gauge, the BP, still reads high. If you're waiting for the pressure to drop, you have already lost 30% of their blood.
Wow.
You have wasted the crucial hour where simple fluids or less aggressive measures might have stabilized them. Therefore, tachycardia, the rising heart rate, and the change in mental status are the real early signals, and they demand immediate action regardless of the blood pressure reading.
So you treat the patient, not the number.
You must treat the physiology of volume loss, not the single number on the monitor.
It's a powerful lesson in physiological reserve. The patient is running on adrenaline and sheer will until the fuel tank just hits empty. And once the BP drops, you know their reserve is gone.
Exactly. Now that we've established how to diagnose the crisis, we pivot to intervention. Modern resuscitation demands we treat blood components as precise doses, much like pharmaceuticals, with quantifiable effects.
Right.
We must move beyond just giving blood to strategic component replacement.
Let's start with the most obvious replacement component, packed red blood cells, or PRBCs. We're using these to carry oxygen. So what is the expected physiological return for a standard dose?
1 unit of PRBCs given to an average adult should raise the hemoglobin concentration by approximately 1 gram per deciliter. That's your dose-effect relationship. But, and this is crucial, the source explicitly cautions, don't chase HB.
That feels like the most counterintuitive advice in a bleeding scenario. I mean, if my patient is bleeding, shouldn't I be trying to restore their oxygen-carrying capacity?
You should, but chasing the HB number becomes a distraction and a trap. In active massive hemorrhage, the transfusion rate often lags behind the bleeding rate.
So you're always playing catch-up.
Always. If you are focused only on getting the HB from 6 to 8, you might be ignoring the fact that the patient is still losing blood and their coagulation system has failed. The priority in this scenario is always, first, stopping the bleeding, and second, replacing the clotting factors to ensure the new blood doesn't just leak out.
I see.
If you stabilize the clot and control the source of the hemorrhage, the HB will naturally recover. If you don't, you are just cycling expensive, precious blood products through the body and, frankly, onto the floor.
Excellent context. Okay, next up, platelets, which are essential for the primary clot formation. What is the standard dose and expected effect?
A standard dose is 1 apheresis unit of platelets. This is expected to raise the platelet count by 30,000 to 60,000 per microliter. We are aiming for a threshold where basic clotting can occur, as platelet function is extremely vulnerable to hypothermia and acidosis.
So you're just trying to get them back in the game?
You are. In massive transfusion, platelets are consumed rapidly, so aggressive replacement is a non-negotiable part of the protocol.
Then we have fresh frozen plasma, or FFP. Walk us through the dosing and primary goal of FFP.
FFP contains all the plasma clotting factors. It is dosed volumetrically, typically 10 to 15 milliliters per kilogram of body weight. Its primary therapeutic goal is correcting coagulation deficiencies. The source states this in terms of correcting international normalized ratio, INR, abnormalities.
Okay, so for the learner, can we unpack what INR actually means in this context?
Think of INR as the stopwatch for how quickly your blood clots. A normal INR is around 1.0. If you are bleeding heavily and receiving massive fluid resuscitation, you are diluting your native clotting factors, and your INR might climb to 2.0 or 3.0.
Meaning the clock is running very slowly.
Very slowly. You are profoundly impaired in forming a clot. FFP is the infusion of the missing clock mechanisms, the factors 2 to the 7, 9X, and among others, to bring that clotting time back down to a safe functional level, usually below 1.5 in a trauma setting.
Finally, we turn to cryoprecipitate, or cryo. This component is highly specialized and often only reached for in major hemorrhage. Why is cryo so crucial?
Cryo is the hyperconcentrated source of the largest, most crucial components needed for a stable clot, specifically fibrinogen.
Fibrinogen is the glue.
It is the molecular glue, the final ingredient that cross-links the clot to make it strong and stable.
So what's the precision dosing for cryo?
The standard dosing guideline is based on the desired target. 1 bag of cryo per 10 kilograms of body weight is expected to increase the fibrinogen level by 50 to 100 milligrams per deciliter.
And what is the clinical target we are aiming for in active bleeding?
This is the application piece that really matters. The target fibrinogen level in active bleeding must be greater than 200 milli-GDL. Fibrinogen is the most sensitive factor to massive loss and dilution, often dropping below this threshold rapidly.
So if you're below that, you're in trouble.
If the patient is below 150 or 100, you physically cannot build a stable clot, no matter how many platelets or PRBCs you give. Knowing that 1 bag per 10 kilos gives you a 50 to 100 mgdl boost allows you to quickly calculate, for instance, that a 70-kilogram patient needs 7 bags of cryo to jumpstart the clotting mechanism.
And move them decisively above that critical 200 mg/dL floor.
That's true precision medicine.
The moment we transition from the body's internal struggle to the external process of management, we hit logistics. And this material makes it abundantly clear. Managing blood is managing a highly perishable biological product. As the expert source says, if the cold chain breaks, the safety chain breaks.
Absolutely. The temperature control dictates both the viability and the safety of the product. Let's look at the storage rules, starting with PRBCs.
Packed red blood cells, the oxygen carriers.
They require rigorous cold storage, 2 to 6 degrees Celsius. This temperature range dramatically slows the metabolism of the cells and, most importantly, minimizes the risk of bacterial proliferation.
And that gives them a decent shelf life.
It does, a relatively long shelf life of 35 to 42 days. However, the operational note we need to focus on is that older units contain high levels of potassium.
And why is that accumulation of potassium so dangerous in a massive transfusion scenario?
As red blood cells age in storage, their active ion pumps, which normally keep potassium contained inside the cell, they begin to fail. Potassium leaks out into the surrounding plasma, the storage solution.
I see.
If you transfuse several units of this older high-potassium blood rapidly, you are effectively giving the patient a massive potassium bolus, leading to hyperkalemia.
And why does hyperkalemia matter so acutely?
The heart's electrical system is exquisitely sensitive to potassium concentration. An acute spike can destabilize the heart muscle's action potential, leading to fatal cardiac arrhythmias.
Wow.
This is why in massive transfusion protocols, clinicians must often monitor serum potassium and give calcium, which helps stabilize the cardiac membrane against the effects of high potassium. This high K+ risk is a subtle but profound danger specific to stored blood.
Now, platelets. They defy the cold chain logic.
They do. Platelets are stored at room temperature, 20 to 24 degrees Celsius, and their shelf life is a very constrained 5 days. This leads us to the Viva question from the source. Why are platelets not refrigerated?
Because refrigeration deactivates them. Right?
Precisely. Cold storage causes platelets to undergo a shape change, becoming spherical and losing their essential disc-like form needed for aggregation. They essentially become therapeutically useless if chilled.
So they need to stay warm.
Maintaining function requires warmth and, crucially, constant, gentle agitation to prevent clumping and maximize their metabolic activity. This warm storage environment, however, is exactly why they have the shortest shelf life and the highest inherent risk of bacterial growth, demanding extraordinarily strict handling protocols.
Finally, we have the frozen components: plasma, FFP, and cryoprecipitate.
These are stored at ultra-cold temperatures, generally -30 degrees Celsius or colder, which halts metabolic activity and gives them a shelf life of up to 1 year. The logistical bottleneck here is the thawing process.
Right, it takes time.
Thawing FFP or cryo takes time, sometimes 30 to 45 minutes, which can be too long in an emergency. Hence, trauma centers often have designated rapid thawers, or they may store pre-thawed liquid plasma, though this dramatically reduces its shelf life. Cryoprecipitant is also usually pooled into therapeutic doses before issue, which simplifies administration.
Okay, moving from the cold chain to the human chain, let's discuss medical, legal, and clerical safety. We are talking about the protocol that prevents the wrong blood from entering the wrong patient.
This is the single most important safety mechanism. It starts with two things: informed consent, ensuring the patient or their legal proxy understands the necessity and risks, and the two-person verification process.
Let's talk operationally. What exactly does two-person verification look like at the bedside?
It is the ultimate administrative firewall. Two qualified individuals must stand at the patient's bedside immediately before connecting the tubing and simultaneously confirm multiple points.
They're checking everything.
Everything. They must match the identification on the blood unit tag donor number, expiration, blood type against the patient's physical identification band and their corresponding chart. Ideally, the patient is also asked to state their full name and date of birth. This is not a quick glance. It's a deliberate, mandatory cross-check.
And once the blood starts flowing, the documentation requirements are stringent.
Absolutely. Clinicians must record the precise start and end times of the transfusion and perform continuous monitoring, documenting patient vitals, HR, BP, temperature at regular defined intervals throughout the entire process.
And if anything goes wrong,
Any deviation from the norm, no matter how minor, constitutes a transfusion reaction and triggers mandatory legal reporting to the blood bank and regulatory agencies.
this leads to the source's most powerful and sobering warning, one that must stick with every professional. Clerical errors kill more than incompatibility.
That statement cuts right to the heart of patient safety and transfusion. Our laboratory techniques cross-matching blood are nearly flawless. The vast majority of catastrophic, fatal, acute hemolytic reactions happen because of administrative failure.
A human error.
Often a simple mislabeled tube or giving the right blood to the wrong patient. That human process error bypasses every scientific check we have. The implication is profound. Safety is about procedure and human discipline, not just advanced technology. Reinforcing the meticulous, boring steps of verification is the most effective safety measure we possess.
Despite the tightest protocols, reactions happen. The patient may present with fever, chills, hives, or sudden shortness of breath. When this occurs, there's no time for guesswork. Immediate systematic action is critical, and the source provides a 6-step algorithm that is mandatory.
This algorithm is designed to ensure two immediate things happen: preventing further harm and initiating rapid diagnosis.
Okay, walk us through the 6 steps of the transfusion reaction algorithm.
Step 1. Stopping the transfusion immediately. The needle stays in, but the clamp closes on the blood product tubing. Step 2. Maintain the IV line with saline. You need that venous access for volume support in emergency drugs, so you switch the line to a continuous drip of normal saline to keep the vein open and flush out the immediate area.
Step 3 sends us straight back to that clerical error warning.
Precisely. Step 3. Recheck patient ID and bag labels. If the reaction is severe and acute, you must confirm you haven't just made a fatal process error. This immediate recheck can save time and guide the rest of your management.
Okay, steps 4 and 5 involve the blood bank and the lab.
Step 4. Inform the blood bank immediately. They need to quarantine the unit, halt its usage, and check for reactions in other recipients of blood from the same batch. Step 5. Send the necessary samples. This involves sending the residual blood bag and its attached tubing, along with a fresh post-transfusion blood sample and urine sample from the patient. The lab then performs a complete investigation for hemolysis or bacterial contamination.
And the final, flexible step, supportive care.
Step 6. Provide supportive care. This is dictated by the reaction type. Hives, give antihistamines. Fever and chills, maybe give acetaminophen. But for severe, life-threatening complications, you may need steroids, aggressive respiratory support, vasopressors for shock, or diuretics for fluid overload.
That distinction in supportive care leads us directly to differentiating the two most critical, life-threatening pulmonary complications, Trachelai and TACO.
Yeah.
Clinically, they look similar. The patient is in respiratory distress, but the treatment is dangerously opposite.
This is a high-stakes differential diagnosis. We use the mnemonic for the learner. TACO equals too much fluid. Trachelai equals lung injury.
Let's define the cause and mechanism, emphasizing the difference.
TACO or transfusion-associated circulatory overload, is purely mechanical. It is fluid overload. The patient's cardiac or renal function is compromised, and they simply cannot handle the rate or volume of the infusion, leading to hydrostatic pressure pushing fluid into the lungs.
And Turale.
Turale, or transfusion-related acute lung injury, is immunological. It's caused by donor antibodies, often anti-HLA antibodies, reacting with the recipient's neutrophils in the lungs, triggering a massive, non-cardiogenic inflammatory leak. It is true, direct lung injury.
The onset can be similar, though TACO tends to be quicker. But the key clinical differentiators highlighted in the exam corner are based on cardiovascular dynamics.
Let's focus on blood pressure.
This is the single most critical piece of information. Turale causes hypotension, a drop in BP.
Why?
Because the systemic inflammatory cascade triggered by the lung injury causes massive vasodilation and increased capillary permeability everywhere, driving the patient into a state of distributive shock.
Okay, so Turale, BP down. What about TACO? Conversely, TACO causes hypertension, an increase in BP. The patient is hypervolemic, they have too much volume, increasing cardiac preload dramatically, which manifests as elevated blood pressure.
If you mix those two up, the consequences are severe. Giving a hypotensive Turale patient a diuretic would drain their remaining circulating volume, worsening their shock.
Exactly.
Giving a hypertensive TACO patient massive fluids would push them into flash pulmonary edema.
Precisely. We also look for physical signs of volume. Where is the jugular venous pressure, or JVP?
Right.
The JVP is a clinical measure of central venous pressure. In Turale, since the problem is inflammatory leak and not volume overload, the JVP is typically normal. In TACO, the JVP is raised because the central circulation is congested due to the excessive volume.
Which brings us to the final practical distinction: response to diuretics.
Since TACO is a fluid volume problem, aggressive diuretic use will result in rapid diuresis, a quick drop in JVP, and clinical improvement. Yes, there is a response. In Turale, because the underlying issue is lung inflammation and capillary damage, the diuretic will have no response on the pulmonary edema itself. And as we noted, it might dangerously worsen the systemic hypotension.
So understanding those 5 points of distinction is vital for choosing the correct and life-saving path.
It is.
We shift now to the philosophical and tactical approach for managing the most extreme cases of bleeding, damage control resuscitation, or DCR. This is the paradigm used in major trauma, moving aggressively away from historical models that prioritized crystalloid fluids.
DCR is a strategic framework that understands that physiology must be fixed before definitive anatomy. The key principles are clear. Achieve rapid hemorrhage control, minimize the use of non-blood fluids, seminize crystalloids, and administer early tranexamic acid, or TXA.
Let's focus on that philosophical heart: the prevention and breaking of the lethal triad. We need to detail the three elements and, crucially, how they feed each other into an inescapable spiral.
The three elements are hypothermia, acidosis, and coagulopathy. They do not act independently, they are mutually reinforcing.
Okay, so let's start with the central factor in trauma coagulopathy, the inability of the blood to clot effectively.
Coagulopathy starts due to factor dilution from crystalloid use and factor consumption from active bleeding. This inability to clot is then immediately and dramatically worsened by the second factor, hypothermia.
Cold?
As the patient's core body temperature drops below 35 degrees Celsius, the chemical reactions necessary for the clotting cascade slow down exponentially. Platelets also become sluggish and unable to aggregate properly. It's simple physics. Cold enzymes don't work efficiently. The patient bleeds more because they're cold.
And the more they bleed, the more heat they lose, which reinforces the hypothermia. This whole downward slide is then pushed further by acidosis.
Correct. Acidosis stems from hemorrhagic shock.
Oh.
Poor perfusion forces tissues into anaerobic metabolism, dumping lactic acid into the bloodstream. When the patient's blood pH drops, that acid directly affects the three-dimensional shape of the clotting factors.
That changes them.
The proteins necessary for clotting literally stop functioning in an overly acidic environment. They are effectively denatured or inactivated. So you have a cold patient who is now acidic, whose already consumed clotting factors are completely non-functional.
The result is a cycle. Bleeding causes shock. Shock causes hypothermia and acidosis. Hypothermia and acidosis cause uncontrollable bleeding. It is a spiral toward death.
The goal of DCR is to break that vicious cycle, often before definitive surgery even begins.
Yeah.
This is why the guiding philosophy quoted in the source is so insightful. Surgery is temporary. Physiology is priority.
Meaning?
The surgeon's primary role in the initial damage control phase might be limited to quickly packing the abdomen or ligating a major vessel, just enough to halt the immediate gross hemorrhage. But the medical team's priority is stabilizing the internal environment. If you don't aggressively warm the patient, correct their pH, and replace their clotting factors, any surgical repair will simply hemorrhage through the suture lines due to the severe coagulopathy. You must stabilize the boat before patching the hole.
So the final summary tactics for DCR focus entirely on interrupting that triad.
They do. The core strategies are: don't chase HB, treat bleeding first, adopt a balanced transfusion ratio, the widely accepted standard being 1.1.1.
1 to 1 to 1.
1 unit of PRBCs to 1 unit of fresh frozen plasma to 1 unit of platelets. This balanced approach ensures you are replacing oxygen carriers, clotting factors, and primary clotting cells simultaneously.
And what are the active steps to fight hypothermia and acidosis?
To fight hypothermia, you must warm everything. All transfused blood products and all intravenous fluids must pass through rapid warming devices. To fight acidosis and coagulopathy, two things are non-negotiable: early administration of TXA, which helps stabilize existing clots, and crucially, early replacement of calcium.
Why is calcium replacement such a major tactical consideration in MTP?
Because the entire premise of stored blood is the use of citrate, an anticoagulant, to bind up calcium in the donated unit, preventing it from clotting in the bag. When you transfuse large volumes of blood containing citrate, that citrate binds to the patient's circulating free calcium. This rapidly induces hypocalcemia, which dramatically impairs cardiac contractility and is an essential cofactor for nearly every step in the clotting cascade.
So without calcium, nothing works.
The patient's heart will fail, and their clotting factors will remain inactive. If you are trying to break the spiral, you must replace calcium constantly.
Let's briefly touch on the use of autologous blood techniques, using the patient's own blood, which serves as another method of minimizing the risks associated with donor blood.
These techniques are vital, especially in elective or semi-elective surgeries with high anticipated blood loss. The sources mention three main methods: preoperative donation, where the patient banks their own blood weeks before surgery; acute normovolemic hemodilution, where blood is withdrawn right before the operation and replaced with crystalloids, then returned later; and cell saver technology, which continuously suctions, washes, and returns blood lost during surgery.
And the benefit is obvious.
The overarching benefit of all these is a significant decrease in the risks of alloimmunization and transfusion reactions, since the blood is autologous.
Finally, we have specific nuances for two high-risk populations: pediatrics and obstetrics, starting with children.
In pediatrics, precision is magnified. Dosing is strictly based on milliliters per kilogram, as there is zero margin for error. Transfusing an adult dose to a child would be fatal volume overload. The primary operational warning, however, is the high GH risk of hypothermia.
Because they're so small.
Children have a much greater surface area to volume ratio than adults, meaning they lose heat rapidly. This accelerates the lethal triad faster than in adults, necessitating extraordinarily aggressive warming efforts.
And for obstetrics, the focus is almost entirely on postpartum hemorrhage, or PPH.
PPH is a time-sensitive, massive hemorrhage event. Management involves very early initiation of the massive transfusion protocol, focusing particularly on fibrinogen maintenance. PPH frequently involves a primary consumption coagulopathy, where the fibrinogen is used up almost instantaneously.
So you need cryo and you need it fast.
Aggressive, cryoprecipitate administration is often required faster than in blunt trauma.
The source poses a great Viva question related to obstetric management. Why is anti-D prophylaxis needed postpartum?
This relates to Rh incompatibility. If an Rh-negative mother gives birth to an Rh-positive baby, some of the fetal red cells may cross the placenta during delivery. The mother's immune system recognizes those cells as foreign and begins synthesizing Rh antibodies.
Okay.
Anti-D immunoglobulin is administered postpartum to neutralize those fetal red cells before the mother's immune system has time to generate a long-term memory response. If she develops those antibodies, they will attack any future Rh-positive fetus, causing severe hemolytic disease of the newborn.
So the timing postpartum is critical to prevent sensitization for the next pregnancy.
That's exactly right.
We've built a comprehensive structure of knowledge, from recognition and precise dosing to safety protocols and advanced trauma strategies. Let's briefly consider what's on the horizon in blood management.
The long-term goal for trauma care is solving the logistical nightmare of blood storage. That brings us to blood substitutes products that can carry oxygen without needing refrigeration or cross-matching. The sources mention HBOCs, or hemoglobin-based oxygen carriers, and perfluorocarbons.
Where do these stand in clinical use today? Are they the solution yet?
Not yet. They're still evolving. HBOCs often run into issues with toxicity and peripheral vasoconstriction, sometimes causing elevated blood pressure. Perfluorocarbons are pure oxygen carriers, but they require the patient to breathe near 100% oxygen to work effectively.
So still a ways to go.
While research is intense, the current reality remains limited clinical use. They solve the logistical problem of stability, but they haven't yet perfected the biological function without side effects. They represent the theoretical future of pre-hospital trauma care, but donated human blood remains the gold standard.
Before we conclude, let's use the Sources Exam Corner review to lock in the highest impact facts, the things that should be at the top of your mind in a crisis situation.
Let's test the retention.
Fact 1. What is the first physiological sign of acute blood loss preceding a drop in pressure?
Tachycardia. The body speeds up the pump before the pressure fails.
Fact 2. What is the threshold that generally triggers the massive transfusion protocol, or MTP?
The need for more than 4 units of PRBCs in 1 hour, or the clinical projection that the patient will require replacement of their total blood volume within 24 hours.
Fact 3. Why is there no hypotension in early shock? Explain the mechanism.
The powerful compensatory mechanism of sympathetic vasoconstriction maintains systemic pressure despite significant volume loss in classes 1 and 2.
Fact 4. What specific electrolyte complication is mandatory to replace during MTP, and what is the mechanism?
Hypocalcemia, caused by the citrate preservative in stored blood binding up the patient's free calcium, thus impairing clotting and cardiac function.
Fact 5. The definitive differentiator in blood pressure between TriLi and TACO.
TriLi causes hypotension due to inflammatory shock. TACO causes hypertension due to fluid overload. That guides your decision to give fluids or diuretics.
If you internalize those 5 facts, you have synthesized the core of this deep dive.
You have just navigated a comprehensive analysis of advanced blood transfusion and hemorrhage management. This knowledge shifts you from understanding basic physiology to mastering clinical logistics, safety, and modern resuscitation strategy.
We have meticulously explored why the earliest indicators of shock are heart rate and anxiety, not blood pressure. You now understand the precision required in dosing components like cryoprecipitate, and you know why clerical errors pose a greater threat than incompatibility. Most importantly, you know how to interrupt that devastating downward spiral of the lethal triad.
We must pause to acknowledge the source of this structured, life-saving curriculum. This comprehensive body of work was prepared by Dr. Senthil Kumaran, whose dedication to surgical education is clear. Dr. Kumaran holds his MBBS from Chitpur, Pondicherry, and MS Surgery from Perjamur, Chandigarh, India, and currently serves as an associate professor of surgery at AIIMS Nagpur, India, with over 25 years of post-surgery experience.
We also wish to acknowledge Mr. Nilesh Lodhaji Sir, a noted philanthropist and businessman from Chennai who served as a mentor, guiding the framework and ensuring this educational material delivers maximum impact for future generations of clinicians. This knowledge base is designed to elevate clinical practice globally.
Building on the DCR philosophy that physiology is priority, we realize the challenge is often getting ahead of the clock. We discussed aggressive warming and giving calcium early.
So here's a final provocative thought for you to consider.
Okay. If breaking the hypothermia acidosis coagulopathy spiral is the ultimate goal, and this requires rapid warming and factor replacement, what simple, truly portable technology, be it an instant plasma thawer, a compact whole blood analyzer, or a field-ready warming device, would make the biggest difference to patient outcomes in the first 15 minutes of trauma care, specifically in a resource-limited pre-hospital setting?
Think about the gap between the protocols we just discussed and the reality of a roadside injury. That gap is where innovation must happen. We hope this deep dive has given you a renewed appreciation for the complexity, the risks, and the immense power of modern blood management.